that they say that high ADC values is with malignancy, and this was published on 2013. This was against all previous studies, so we must, in axillary lymph nodes, I think we must depend on the morphology. But regarding the breast lesions, the fusion study and the ADC map helped us many times to localize pathology. Sometimes there was biopsy changes, and we don't know these post-contrast enhancement actually secondary to the biopsy, or this is underlying malignancy. Sometimes we have many false negative results in biopsy, but the diffusion study and the ADC maps helped us to localize the pathology, and the open excisional biopsy was positive. So I think the fusion study with breast lesions helped us many times to localize the pathology and improve our accuracy and specificity. But again, the fusion study in axillary lymph nodes is not accurate at all, because if we scan many axillary lymph nodes, we may have restricted diffusion in these hepatocytes. Even we don't have breast malignancy or underlying breast lesions, and we have restricted diffusion and low ADC values. So we can, I think in my experience, we can depend on the fusion study in axillary lymph nodes. But it may be very beneficial in breast lesions. And this is my experience.
Thank you for sharing your explanation.
We move on.
Thank you very much, Dr. Nurhan, for the excellent presentation. Nuran, for excellent presentation. It was very beneficial for all of us. Moving to the next topic by Dr. Ahmed Samir, application specialist from Philips. He's going to talk to us about MRI-guided biopsies and dynamic CAD. تفضل. لو ممكن حد يجي للمايك.
اديله حتى.
Good afternoon. I would like in this short presentation show you the new tools for enhancement of MRI breast post-processing and analysis. Since MRI is considered one of the important tools for breast diagnosis. There is a new tool which is called DynaCAD. This tool was introduced maybe 5 or 6 years ago, but now it has a great enhancements also to help us to be able to have a precise breast biopsy guided by MRI. So this product can be used with any MRI system, and the main important usage of this tool, which is a software, just to have the dynamic curves in a proper way and in a fast way, and of course we can see the images, all the images, the diffusion, the perfusion, and all other kind of images of the MRI breast. And there is the very nice and easy tool to help us to have the guided biopsy. The DynaCAD breast make an enhancement in the performance in all time points analysis and pharmacokinetics modeling, enhanced workflow and very fast workflow, and of course a very precise tool to target suspicious regions and to take the biopsy. Of course it makes it much more easier and precise, and of course there is a lot of papers showing that using this tool made it a much more precise way to have a guided MRI breast biopsy. So this tool helps to get enhancement in breast disease management and reduce processing time, and of course very nice color overlays only in short and one click. I would like to show you a demo, a very fast demo on a case, how we can do it on this tool. So I just open from the list of cases, one of the cases. So here, first, this is the standard view where I can scroll between all kinds of images, the fat suppression images, the diffusion, and of course the T1 and T2 images. And then I can go to this dynamic curve, just a very fast way to enhance, just to move my cursor to get the proper curves in a proper way. And of course I can scroll around with all images to see if there is a lesion. And finally the last step, which is the interventional tool, which is a very nice and easy tool, just to move the cursor on a lesion, for example here, and then you will see here in this grid where exactly the needle should be inserted, and the depth of the needle should be inserted to what extent, just to be sure that we are reaching the proper point in the breast where there is a lesion, and to be much more accurate. So it's very easy, and in just like as I said, it's in 5 minutes you can have a complete vision about the lesion. I have here a demo for this grid for people who never seen a grid in the breast coil, which is compatible with most of the coils with different vendors. and we can see here the squares which we can use to visualize and to approach the lesion in a proper way. Thank you.
Any questions? I do have a question, Dr. Ahmed. When we take the biopsy, will that tool will be able to put a guided wire or to leave or no?
No, actually, it's just for a biopsy. It will not help us in putting a guided wire or something. And also, it needs a compatible MR compatible needles, which should be available in the place where we use this tool.
Okay, thank you. Any questions? Thank you.
Thank you.
Okay, so moving now on. Thank you, Dr. Ahmed. To my dear friend, Professor Dr. Ashraf Salim. He's the Professor of Radiology at Cairo University and Chairman of the department. Also, he is President of the Egyptian Society of Women's Imaging and a board member of the Egyptian Society of Radiology. Ashraf started many years ago to be interested in women's imaging, and he is a pioneer and still on the forefront of the specialty. Dr. Ashraf is going to give us an interactive case reading. Thank you, Dr. Ashraf.
Okay, good afternoon, everybody. First of all, I'd like to thank you all for your attendance here in this conference, and I would like to thank all the organizing committee, and particular thanks to my colleague Dr. Nagla Abdulrazik for organizing such a wonderful radiology session. And I will start here with an interactive session. And what I mean by an interactive is that I want everybody to wake up and to be interactive, okay? Not necessarily shouting or yelling. Anybody who can share with me all the information, because without being interactive, the session would not have been called interactive. Usually we use the electronic voting system, but unfortunately we couldn't arrange for that. But anyhow, my presentation today would be basically centered on the MRI, and I've heard lots of debates today that I didn't want to really take much of your time. So I said to myself I would answer all what has been discussed yesterday and today from my perspective. And let's go for the first case. Can we switch the light? نقلل النور شوية سنة صغيرة لو سمحت، مش قوي بس عشان أقدر أشوف أو أقفل برضه عشان الناس تبقى انتراكتيف من غير ما يبقوا محرجين. Okay, good. This is the first case, routine mammography. This lady came complaining from thickening, sense of induration at the right area. And as we can see here, there is diffuse density, overall density. What's usually we call this as the ACR type 3, where the density almost involves more than half the breast. Anybody can find any abnormality here Okay, she's coming for the right areola. Anything about the right areola? Yeah, we can see some thickening of the skin, asymmetry. There is some thickening of the periareolar skin. You agree? Okay. So, what's the next step? I mean, there is no mass lesions down there. There's no microcalcifications or macrocalcifications. There's nothing. Just merely thickening. What do you think would be the next step? Ultrasound, definitely. And we should not, and I repeat, whenever we are doing diagnosis, we should do ultrasound in all cases. No BI-RADS, only on mammography. We do BI-RADS at the end after we finish all the examination, mammography and ultrasound. Okay, they did ultrasound, but I will not show you what was there in the ultrasound. And then they wrote the woman for an MRI. And what we see on the MRI. Now, let's go into the basics. How can we describe what we are seeing in the right breast? Would you go for a mass, linear or segmental enhancement, a mass with linear, segmental and foci of enhancement, a mass and foci of enhancement? What would you go for? Raise your voices. 1? Who's with 1? 2? Who's with 2? 2, 3, 4, 5. 3, mass, linear, segmental and foci. Everything almost. Very few. And what about the rest? Those who are not voting. A mass and foci. Okay, 1, maybe 2. So you all disagree, you don't agree on anything of those. Okay, what do we see? Actually, try to describe what you're seeing. We can see, yes, we can see here, there is a nodule here, another mass lesion here. And what's the difference between a focus and a mass? A focus is a tiny, tiny enhancing lesion less than 5 millimeter. This is more than 1 centimeter. One is maybe 12 or 13 millimeter and the other is maybe 2 centimeter or so. And each one has borders, has margin. So these are masses. But is that all? Are we dealing only with 2 masses? No, there are other foci of enhancement in the neighborhood and in between these 2 masses. Do you agree? And what about this? I mean, look at the left breast. We do have, and this is the normal, to find enhancing foci, tiny enhancing foci, less than 5 millimeters, especially if the lady came without respect to the menstrual cycle, like you just discussed in the previously. So this is normal, the tiny foci. This was in the old BI-RADS lexicon called foci of enhancement. Now this has been changed to a background of enhancement, which is usually goes with the fibroadenosis. But if you find 2 separate, alone, slightly bigger foci, these should be considered and not just go as if it's just part of the foci of enhancement like the others. So, to cut it short, this is again the original, and these are the lesions that we are finding in here, and the answer is mass, linear and segmental, and foci of enhancement. So what would be the differential diagnosis? These would be fibroadenoma, adenosis, invasive duct carcinoma. What do you think? Who goes with fibroadenoma? None. Okay. Carcinoma. 1, 2, 3, 4, 5, 6, 7. Okay, now the number is counting. Good. Now you're starting to wake up. Okay. Yes, fully agree. This is an invasive duct carcinoma with DCIS components. And as I will be telling you in the next cases about the DCIS, which is usually not accompanied by mass lesion, just a chain of beads or nodular enhancement, or sometimes diffuse tiny enhancing foci. Okay, second case, mammography. The lady is coming with a palpable right breast mass. She said she has a right breast mass. The mammography actually shows what? Okay, let's try to analyze what's there in the mammography. Just an area of asymmetry in the upper outer quadrant with some maybe prominent ducts, retroareolar. So the next step as usual, no microcalcifications, nothing, maybe one calcified calcification, but anyhow, the tomosynthesis also did not show any added apart from what I said. Okay, the ultrasound. Sometimes we are really confronted with such cases that the mammography findings are subtle and the ultrasound findings are also subtle. Despite the fact that the lady has a lump in her breast. So, the ultrasound, as it's shown here, there are some, the dilated duct that we saw in the mammogram, and the area, some of the heterogeneous, borderless area of hypoechoic area. And what you should do in this, I mean, you have to write down the report, and the report would be, at the end, you would suggest something. And as we know, we have the classification, the BI-RADS. Who would go for a BI-RADS 3 and who would go for BI-RADS 3 first? Let's start with BI-RADS 3. Would you consider this as a duct ectasia and that's it? Or would you go further to say that this is probably BI-RADS 4A or whatever? Let's go for BI-RADS 3. Who agrees? No one agree with BI-RADS 3? BI-RADS 4? Ah, good. So people are now fully awake. Okay, yes. So this really was reported as BI-RADS 4, and MRI was requested. So in the MRI, like my colleagues just explained yesterday and today, about the technique, about the findings in benign and malignant lesions and so on. You have here a set of images, axial T1, axial T2 and inversion recovery, the subtracted images and the MIP of the same case. Remember, we just had on the mammogram just asymmetry in the upper outer quadrant and prominent ducts by ultrasound, as well as subtle heterogeneous hypoechoic area. So this is the MRI. And as you can see, the main finding here is the enhancement. And as you can see, its enhancement is taking most of the outer lower quadrants, maybe upper outer, I don't know recall. But anyhow, this is the enhancing foci. So what's the differential diagnosis when you see clumped enhancement like that, non-mass enhancement? We spoke about the foci and then the mass, and you often hear the term non-mass enhancement, meaning enhancement without borders. no borders, ill-defined, and we call it non-mass enhancement. And as in this case, the clumped foci enhancement, non-mass enhancement. Differential diagnosis. Usually, the first differential diagnosis that we all should be keeping in mind, especially if it is just asymmetry, I mean, the other breast is totally normal, we should definitely think of the DCIS. But not all cases are really DCIS. So I neglected the DCIS, and now what's the diagnosis? Invasive duct carcinoma, duct ectasia, or papillomatosis. Who would go for invasive duct carcinoma? 1, 2, 3, 4, 5, 6. Okay. Now the second is the duct ectasia. Who would go for a duct ectasia? We saw 1 or 2 dilated ducts in the retroaerial region. But are we talking about duct ectasia or secretory disease of the breast? Anybody with number 2? Okay. Number 3, papillomatosis. Who's with papillomatosis? No one. Okay. So papillomatosis is one of the differential diagnoses between an area, segmental area of clumped non-mass enhancement, and it can mimic the DCIS in many cases. So the diagnosis in this case was a papillomatosis. Yes. Why it's not invasive duct carcinoma? Of course, okay, DCIS, I said, okay, this is one of the top on the differential diagnosis list. Papillomatosis, invasive duct carcinoma, usually we see one of these nodules forming a mass, which is not the case here. Okay, case number 3, right breast lump. This, we have a video here. Sorry. It's not working or what? Okay, this is the video. And we can see here there's a mass, an enhancing mass, a big one, or maybe actually more than one mass. Let's go back and see the video again. Yes, there are multiple masses in the right breast, enhancing masses in the right breast. So, the left breast is quite normal, nothing in the right breast. So, what's your diagnosis? Put a differential list. Are we dealing with multiple fibroadenoma or a multicentric carcinoma or multiple infected cysts? Who would go for the first diagnosis? Fibroadenoma. 1, 2, 3, 4, no cheating. 3, 4, okay. Multiple or multicentric carcinoma. 1, maybe 2. Okay, infected cysts. 1, 2, infected cysts. Okay. Okay, I'll start with number 3. Infected cysts. A cyst is a cyst. Cysts do not enhance. Cysts are fluids that show only when they are infected marginal enhancement. We didn't see any fluid inside the cyst. One would say, okay, this is a contrast enhancement, and the masses are totally enhancing. There's no halo inside to denote there is some fluid. So the cyst typically would not enhance. Sometimes you find a thin rim of enhancement sometimes, but often if it is complicated cyst, you find it a thicker rim of enhancement. For complex cysts, you find masses inside the cyst wall or focal thickening of the cyst wall, which is not the case. Let's go back to the original video. I want to show you something that you should take care of. What's this? What this picture gives us? Don't you notice there are some internal septations, non-enhancing septations that are traversing the big mass here? Can you see these septations? I need an answer, yes or no? I can't hear you. Yes, there are some internal septations, non-enhancing internal septations that are characteristics of fibroadenoma. So, if these, you can recognize these internal septations and are really non-enhancing septations, this is a fibroadenoma. So please, always look for these internal septations. So the diagnosis is actually multiple fibroadenoma. So, patient coming for routine screening MRI, she has a positive family history. Did you notice anything? Yes? Okay, I repeat it again. Show it to you again. Look at the left breast and compare it with the right breast. Always do this. So, I think everybody noticed that we have asymmetrical enhancement in the left breast compared to the right. Did you see all you? Did you see this?
Yes.
Okay. And this asymmetry in the enhancement is confined to the lower half of the left breast, the last images. As you can see, this is the enhancement. As in the first case, we have here more or less clumped enhancing, non-enhancing foci that are clumped together and actually spread out through the lower half of the breast, in comparison to the right breast where there is nothing. One would say, okay, this is an adenosis. Yeah, but adenosis is usually bilateral disease, although it might be in one side more than the other. But here, no. This is quite unusual that we see this pattern of enhancement. So, the question is, how would you describe the MRI finding in the left breast? Would you go for just description? This is diffuse asymmetrical and clumped enhancement, diffuse asymmetrical glandular enhancement, mass enhancement, or multiple enhancing foci. The description, the term that you use in your description is really reflecting your experience and knowledge in interpreting the MRI. So, who would go for the diffuse asymmetrical and clumped enhancement? How many? 1, 2, maybe 3. Okay, diffuse asymmetrical glandular enhancement. 1, 2, 3, 4, 5, maybe 6. Okay. Mass-like enhancement. 1. Multiple enhancing foci. 1, 2, 3, 4. Okay. One would ask, come on, what's really importance? It's just the enhancement. No, the pattern of enhancement would put in your mind what's the differential diagnosis that we're looking for. So, let's go for number 1. Diffuse asymmetrical clumps. Diffuse? It is diffuse, involving more than one area of the breast. Asymmetrical? Yes, it is asymmetrical. We all agree about that. Clumps? Yes, there are clumped together, but spread on a diffuse area. Diffuse asymmetrical glandular enhancement. It's the same, but we have a glandular. It's not really glandular. It's just involving the lower half of the breast. It's not the whole breast, and it is asymmetrical. So it's not a glandular. Definitely it's not a mass. We don't have mass with borders or margin. Multiple enhancing foci, the term should only be restricted to those less than 5 millimeter and the background enhancement, like I said. So the answer would be number 1. But, so what's really of value? Are we just write down the description and finish? No, we have to have a differential diagnosis, a list of differential diagnoses. If we are now having diffuse asymmetrical and clumped enhancement, always we think of the DCIS, as I said. DCIS. And there are many debates about the usefulness or the value or the sensitivity of MRI in detecting DCIS. Like in yesterday's session, I think many people handled this issue. But be careful, we have to look for that. One further point that I want really to emphasize here, from what I see in the market, people will not stick to the proper dose of intravenous contrast. And if you don't give the proper dose of intravenous contrast, don't expect that you will have good results. All what have been written in the literature only deals with the proper amount of intravenous contrast. I know, because of our really bad financial issues, that many of the centers use half the dose or maybe 1/4 of the dose, but this should be abandoned. If you're really doing MRI breast, the dose is 1 millimole per kilogram body weight. No, don't try to negotiate, don't try to make yourself clever and to make some profit. No, this is wrong. Please stop doing it. Otherwise, don't do contrast enhanced MRI. Okay, case number 5. 50-year-old woman. She had history of bilateral conservative surgery, and she's done PET CT. Why PET CT? One would say, why PET CT? Some of the patients, for follow-up, especially if she has double cancer or bilateral cancer, now the best modality to detect any metastatic disease is the PET CT. So she's done the PET CT, and what did the PET CT get is just, as you can see here, a tiny little uptake in the right breast. That's all. So the patient was referred for MRI. Mammogram first, before the MRI. This is the mammogram of the right breast. Can you detect anything? Just diffuse density, but no discrete masses were found. So the MRI, look carefully for the MRI. Anybody So anything abnormal? Okay, make it easy for you. I'll repeat it again. And I'll help you. Okay, we are coming from down to up, inferior to superior. Okay, now look, one lesion that showed up, second lesion that showed up. Everybody saw this? Anybody didn't see these two lesions, enhancing lesions? Okay. So, these are the images. As we can see, we have two lesions here actually. This is 1 and this is 2. 1, 2. 1 is bigger than 2. But let's go in anatomically speaking. What do you think is 1 is either what? 1 is probably in the axilla, lying very high and very lateral and very posterior. So probably this is an axillary node. If you can see what I'm seeing in these images, yes, you can see it. Okay. See, this lesion has what in the center? Has a lucid, a non-enhancing lucency in the center. Okay? And the other lesion, how would you describe this lesion? Is it spiculated, round, oval, well-defined, ill-defined, what? Well-defined, oval. Would you agree with that? Hey, wake up. Will you agree that this is a round or an oval, well-defined lesion? Yes. Okay, good. And the second one really has a triangular or an angular anterior margin. Okay? And when you report that a lady has done conservative treatment for both breasts, now in the follow-up study, she has one of these lesions have got an uptake in the PET-CT and a suspicious finding in the MRI, this lesion, with a suspicious axillary node. What would you go for? Will you go for a highly suspicious, or benign? Of course, we all agree that this is suspicious. But the challenge for you as a radiologist, when you say this is suspicious, what do you expect from the surgeon or the oncologist? To ask for, yes, for a pathology. You know, the small lesion in the breast measured 3 millimeters. And the axillary node measures 7 millimeters. So a clever radiologist would do what? Ultrasound, right? Noran is laughing. But anyhow, before we do an ultrasound, we just answer this. Is it benign? Probably benign, suspicious or malignant. I'm sure all of you would go for BI-RADS 4, right? Okay, good. Now comes the second challenge. How can we take a biopsy from a 3 millimeter lesion? Yes, we can. And that's how it was done. You can see this is the shaft of the needle. Where is it? Yes. The needle going into this suspicious tiny little nodule. And this was the axillary node. We were just happy to get biopsy from the lesion, which turned out to be what? Fibroadenoma, sclerosing adenosis, invasive duct carcinoma, fibrocystic changes. Who would go for number 1, fibroadenoma? No one. Yes. Very good. 2, sclerosing adenosis. No one? Okay. Recurrent invasive duct carcinoma. Yes, many hands. All clever. Very, very nice. And then fibrocystic changes, of course. No way. Yes, turned out to be a recurrent invasive duct carcinoma. Now, the message here, whenever you have a equivocal mammogram, equivocal ultrasound, patients did MRI with MRI findings positive. A second look ultrasound is essential. Don't just discard the patient like that and write down your report. No. Bring her back, have a second look ultrasound, like in this case, and then you will find what you're looking for. In most of the cases. I'm saying in most, not in all. In most of the cases. And this would obviate the necessity for doing an MRI-guided biopsy. I know that in Egypt, maybe only one of our compression works with the MRI, but if you have a second look ultrasound, you will find most of the lesions that were found by MRI. Okay, case number 6. 44 years old patient. She's underwent pan-hysterectomy for ovarian cancer. This was in March 2005. And she received chemotherapy. On follow-up, she had got elevated tumor marker CA-125. She received no hormone replacement therapy. And now she also has a right heaviness of the right areolar area. Ovarian cancer. Now she has ovarian. She feels some abnormality in her right areola. What's the link between ovarian and breast cancer? What's the link? Anybody knows what's the link? I think you've heard about the BRCA1 and the BRCA2, and those gene carriers are more prone to develop breast cancer and ovarian cancer as well. So be careful for patients with BRCA1 and BRCA2. I know that this is not frequently done in Egypt, but those patients have more prone to develop ovarian cancer and vice versa. Okay, let's go for the MRI. Patients with high risk, do we do routine screening by MRI or not? This is quite debatable. And by high risk, there is we mean more than 20 to 25% more likelihood or has to develop breast cancer than other population. The debate is here. Some people in the States, some of the states in America, they perform mammogram, then after 6 months MRI, and then we go mammogram annually and MRI annually for high-risk patients. So this patient, if she is a gene carrier, so the justification to do her an MRI is valid. One of those high-risk patients also is the one who were treated by radiotherapy, for example, for Hodgkin disease of the mediastinal lymph nodes. These are now considered as high risk. So, what are we seeing in the MRI? A mass, right? A mass with a border. But look, the signal intensity. I'm providing you with the axial T1, the axial inversion recovery images, and the sagittal T2. So, let's go for the MRI. The MRI showed what? a marginally enhancing mass, with the center is non-enhancing. Right? Go back. This is the pictures of the T1, T2 and sagittal T2, and this is the MRI. What's your diagnosis? Now I want you all to share. Number one, infected cyst. Who would go for an infected cyst? 1, 2, 3, 4, 5,